And so to round out this discussion on Syntonics, Syntonic Phototherapy, let's take a look at accepted, standardized applications of phototherapy and industrial use of color. And so my question for the AI model is, what is the current evidence base for other more established phototherapy applications, like for seasonal affective disorder or dermatology, for comparison? And the response is, to help structure this comparison, the table below outlines established phototherapy applications alongside key characteristics of Syntonics. And so in the first instance, we look at the primary domain. Who is practicing this? And so Syntonic Phototherapy, Spittler's base, is practiced in optometry and in vision therapy. Whereas in established phototherapy modalities, you're seeing more likely psychiatry, dermatology, neonatology. The target wavelengths in Syntonic Phototherapy, we look at specific colors, red, green, blue, and variants in between. And this is delivered via the eyes. In established phototherapy modalities, we have broad spectrum white light for SAD, we have UVB for skin applications, and we have blue for neonatal applications. The proposed mechanism in Syntonic phototherapy is that there's a balancing of the autonomic nervous system via retinal pathways. In established phototherapy modalities, first of all, it's a circadian entrainment for SAD, there's immune modulation for skin responses, and there's a bilirubin breakdown in neonatal cases. So in terms of evidence and quality of systematic reviews, in Syntonic phototherapy it's very low. There's virtually no scientific support. In established phototherapy for SAD, it's very high. For skin applications, again very high. For example, psoriasis, vitiligo, and again very high in the treatment of jaundice. These are high standards in scientific outcomes and reproducibility. So in the clinical status currently for Syntonic phototherapy, it's considered alternative medicine. It's unproven. And in terms of established phototherapy modalities, it's definitely considered first line or standard of care bright light therapy for SAD, for example. And so let's look at these specific modalities and the evidence behind them. Here is a breakdown of how light is used effectively in mainstream medicine, supported by repeatable, rigorous study. And so with respect to seasonal affective disorder, or SAD, and psychiatry, bright white light, 10,000 lux, is a first-line treatment. A 2025 network meta-analysis found white light most effective for alleviating depressive symptoms, though blue and green light also show effects. And then in dermatology, narrowband UVB is the gold standard for psoriasis and vitiligo. It works via immunomodulation and promoting repigmentation, often combined with topical treatments. In neonatology, blue light is standard for jaundice. Research continues to optimize protocols. For instance, intermittent blue light may be as effective as continuous with fewer side effects. And wound healing, or photobiomodulation, both lasers and LEDs promote healing through cellular effects. While evidence is promising, the heterogeneity of parameters makes direct clinical comparisons difficult. And so, in ophthalmology and optometry, certainly myopia abatement with repeated low-level red light therapy, RL, appears to be one of the most promising newer treatments for slowing myopia progression, especially in children. However, there are some important caveats. Several recent systematic reviews and meta-analyses have found that RL significantly slows axial length growth and myopic refractive progression. So these are good things. The evidence is now based on multiple randomized and observational studies involving thousands of children, mostly in China. Recent reviews generally conclude that RL is effective for myopia control, often performing similarly to or better than some established interventions. In these cases, while we don't fully understand the mechanisms at play, the fact that there's an effect is decided science, and the observations themselves now help to guide further research only because the science is rigorous and repeatable. These studies are standardized, repeatable. Caution is advised when using non-standard light sources and when exceeding recommended exposure levels. Recent research shows disruption of foveal tissue with overexposure to red light. Let's now turn to amblyopia treatment. 670 nanometer photobiomodulation for amblyopia is a very different area from the better-known red light therapy for myopia control. The study that has gotten attention in optometric circles is the 2023-2024 pilot study by Ahadi and colleagues. They enrolled 16 children aged 8 to 13 with strabismic amblyopia and compared conventional patching plus nearwork against patching plus 670 nanometer PBM. The PBM group received 670 nanometer light exposure for 4 minutes, 3 times per week. After 3 months, visual acuity improved by about 2.5 lines in the PBM group versus about 1.4 lines in the control group. No treatment-related adverse effects were reported. What makes this interesting is the proposed mechanism. The traditional view is that amblyopia is largely a cortical disorder, abnormal visual development in the brain. PBM proponents argue that 670 nanometer light may improve mitochondrial function by acting on cytochrome C oxidase, increasing ATP production and reducing oxidative stress. The hypothesis is that better retinal and neural metabolic function could enhance plasticity in the amblyopic visual pathway, making treatments like patching more effective. This idea is biologically plausible and has been investigated in retinal diseases as well. However, I would characterize the evidence today as intriguing but preliminary. The amblyopia study was very small, only 16 subjects. It was not a large multi-center randomized controlled trial. Follow-up on it was very short. And also, the treatment was used with other conventional therapy, not as a replacement. And then finally, independent replication is still limited. From an evidence-based optometry standpoint, I would place 670 nanometer PBM in roughly this category. And we'll show this table here. And so the treatment, optical correction and patching, the evidence level is very strong. Atropine penalization, the evidence is very strong. Binocular and dichoptic therapies, the evidence is moderate, but there. Perceptual learning, once again, the evidence is moderate, but present. 670 nanometer photobiomodulation, or PBM, is rated as early stage or experimental. One reason clinicians are paying attention, despite the limited evidence, is that the reported effect size in the pilot study was larger than many would expect from a simple adjunctive therapy. If replicated, it could become a useful enhancer of standard treatment rather than a replacement for it. A particularly interesting question, which remains largely unanswered, is whether PBM could help older children or adults with residual amblyopia, where conventional patching tends to work less well. Historically, there have been small reports suggesting visual improvement in adults treated with low-level laser PBM approaches, but the evidence again is nowhere near robust enough to draw firm conclusions. My assessment of the field in 2026 is that 670 nanometer PBM for amblyopia is no longer fringe. It has enough biological rationale and early clinical data to be taken seriously, but it is still several large randomized trials away from being considered standard of care. The signal is promising. The evidence base is still thin. Let me put that study up on the screen here for you. You can pause, take a picture of it, look it up for yourself if you like. It's a very promising domain, potentially. So why the difference in evidence? The contrast between these fields and Syntonics is striking and boils down to a few key factors. Number one, mechanistic clarity. Established therapies have clearly defined biological targets, for example UVB, suppressing T cells in the skin, whereas Syntonics relies on the unproven theory of balancing the autonomic nervous system via color. Balancing itself, a term that needs definition. Next, the rigor of research. The dermatology and psychiatry fields rely on large, double-masked, randomized controlled trials, or RCTs. Syntonics lacks these controls, making it impossible to rule out placebo effects. Next, and finally, reproducibility. UVB or blue light protocols are standardized. Syntonics prescriptions often vary widely by practitioner, hindering study validation. And likewise, in terms of the diagnostic process, there is no standard process for diagnostics in Syntonics, largely because the markers are almost meaningless. A note for objective comparison. When comparing, it is helpful to distinguish between the eye as the target organ and the eye as a portal. Established therapies use light for local effects on the skin, like UVB, or to entrain circadian rhythms, SAD, via the whole retina. Syntonics relies on the assumption that specific colors have unique therapeutic benefits on the brain's autonomic centers. While optometry accepts that near-work affects accommodation, the jump to color-specific neurological healing is where the evidence fails to support the clinical claims. Let's take a few minutes and talk about Irlen syndrome and Irlen lenses while we're at it. Are Irlen lenses considered effective therapy? In short, Irlen lenses are not generally considered an evidence-based treatment for amblyopia, dyslexia, reading disorders, ADHD, or most visual processing problems. What are Irlen lenses? Irlen lenses, also called Irlen filters or spectral filters, are individually tinted colored lenses prescribed based on the theory of scotopic sensitivity syndrome, or Irlen syndrome. The claim is that certain wavelengths of light cause visual perceptual distortions, and that customized tints can reduce symptoms such as eye strain while reading, glare sensitivity, headaches, visual distortions of text, reading difficulties. What does the evidence show? The scientific evidence has generally been disappointing. Multiple reviews from organizations in ophthalmology, pediatrics, psychology, and education have concluded that there is insufficient evidence that colored overlays or tinted lenses improve reading ability, dyslexia, or learning outcomes beyond placebo effects or non-specific benefits, and these were reviewed earlier. Policy statements from organizations such as the American Academy of Pediatrics, the American Academy of Ophthalmology, and related groups have stated that vision therapies based on colored lenses are not supported as treatments for learning disabilities. What about amblyopia? For amblyopia specifically, there is no strong evidence that Irlen lenses improve visual acuity, binocular vision, or suppression in the way that established treatments do. So with respect to treatments for amblyopia, the evidence-supported treatments remain: appropriate refractive correction, patching, atropine penalization, some binocular dichoptic therapies, emerging approaches such as perceptual learning. Irlen lenses are not considered a standard amblyopia treatment in mainstream optometry or ophthalmology. Why do some people swear by them? This is where the discussion gets more nuanced. Some individuals genuinely report less glare, greater visual comfort, reduced headaches, improved reading endurance. The subjective benefits may be real for certain people, especially those with migraine, photophobia or light sensitivity, and certain neurological conditions. But subjective comfort is different from demonstrating objective improvements in reading skill, visual development, and amblyopia outcomes. Now, let's compare that with 670 nanometer PBM. Interestingly, the current evidence for 670 nanometer PBM in amblyopia is arguably more biologically plausible than the evidence for Irlen lenses, despite PBM being much newer. The PBM literature is investigating measurable physiological mechanisms through mitochondrial function, ATP production, neuroplasticity, retinal metabolism, whereas Irlen theory has struggled to establish a reproducible underlying mechanism or consistent objective treatment effects. So the bottom line: as a comfort aid, some people find Irlen lenses helpful. As a treatment for amblyopia, the evidence is weak to non-existent. As a treatment for dyslexia or reading disorders, major professional organizations generally conclude the evidence is insufficient. As a medical therapy, they are not regarded as standard evidence-based care. If your interest is amblyopia and neuroplasticity, the current research frontier is much more focused on binocular therapies, perceptual learning, virtual reality approaches, and newer interventions like the PBM than on spectral filters. And with that said, we'll leave the discussion there, and perhaps that satisfies the discussion on Syntonics for the moment. Thanks again for listening.